there's a couple of unifying factors, 3 real pillars that CAMS stands on, and that CAMS needs, or none of that therapeutic stuff is going to happen. One is empathy with suicidal states. If you're here, you took a risk. It takes incredible vulnerability for somebody to be willing to come in and talk with a healthcare provider. I don't know if I'm going to be shamed. I don't know if something's going to be taken away from me. I don't know what's going to happen. But things were bad enough that I came in anyway. That's incredibly vulnerable and candidly brave. And you're not a broken person for being stuck here. I want to be able to empathize with you for coming in with your pain and connect with you collaboratively. The C in CAMS isn't here for no reason. Without collaboration, this process doesn't work. Just like it similarly won't work without the third pillar, honesty. Something that many of us on multidisciplinary teams know already has to happen, but often in one direction. I know, for example, that if you're not honest with me as a therapist, this process isn't going to go very far. I need you and want you to be honest with me about where you are, about what you're feeling, about what's going on for you. But how can I get that without being honest in turn? I need to be honest with you about a lot of things. I need to be honest with you about who I am, how I think about suicide. I want to be honest with you about my role as a provider, what's hospitalizable, what's not, but how I approach treatment, how I approach an assessment like CAMS, how I approach the connection I want to foster with you so that you get something different than any part of that cycle you might have already been on. We have to put these pillars in practice in a way that's suicide focused, which is another essential component of CAMS, that it's a suicide focused framework and treatment. What does that mean? It means that for this person, I want to understand why you want to die and the specific relationship with suicide that you have, which runs contrary to a lot of popular belief and a lot of understandings of suicide, particularly when we hear things like this. Shouldn't you just treat depression? Shouldn't you just make sure to get at depression, because if you do that, won't suicide kind of trickle away? It doesn't work like that. Even though you can take a look at something like the DSM and find suicide listed as the symptom of a problem, that's not how we think about it. Take depression. Many people who are depressed are not suicidal. Many people who are suicidal, who are presenting to the settings we're describing, like EDs, like empath units, are not depressed. They don't meet criteria. Maybe they don't meet criteria for any mental health disorder or diagnosis. What do you do there if suicide is the symptom of a problem? You get stuck. And it certainly makes it hard to figure out what effective risk assessment, management, and treatment would be. CAMS sidesteps this sticking point entirely because it centers around a collaborative conversation where I try to figure out, why do you want to die? What is your unique, idiosyncratic relationship with suicide? And we do this in a way where we literally sit side by side, if you're willing to let me, co-authoring stabilization and treatment plans together, going through the forms, seeing things the way that you do, primarily when we get to a form that's the heartbeat of CAMS, the central aspect of this, a multi-purpose tool called the Suicide Status Form. It's a set of forms that assess risk, provides prevention planning with stabilization planning and lethal means counseling, and sets the course for the treatment that we get to do together. Part of the reason it's so therapeutic is because it starts with a first part done together by the patient with a clinician sitting next to them, centered around the story of their pain. When you go through this first page, there are questions getting things like psychological pain, stress, agitation, hopelessness, and self-hate. And we ask people to put a number on this. How would you rate this for yourself? But crucially, we ask them to describe it. We balance those numbers with your answers. And then let's build on that with asking, what are your reasons for living and dying? What's going on for you? And in the process of describing this, we're listening carefully and actively. What is it that you find most painful? Not what your parents would say, not what your kids would say. What do you say? You hate most about yourself. You feel most hopeless about. And how do we build on that conceptualization with your reasons for living and dying? How much do you wish to live, wish to die? What's something that would take this off the table? Practical or magical, what's something that would fundamentally, one shot, change your relationship with suicide? And as we're going through this, it's essential that this person feels heard, that this person feels like they're worth being uncomfortable for, and that they feel like this clinician doesn't want to be anywhere except in my corner. And over the course of this assessment, as we build off of this and sharpen the story, we come up with a term that you're going to hear a lot if you go down this road and your organization implements CAMs: drivers. What is driving suicide for you? In fact, we'll specifically want to target two. What are two direct drivers, two problems suicide's trying to solve that we get to focus on together in treatment? Now, in the broader treatment course, over the course of that 6 to 8 sessions, a clinician will work with you, with clients, to treat these drivers until they've moved from a place of thinking about suicide and feeling unstable to a place of stability, where they feel they can manage the thoughts and feelings as they come up, where they feel more skilled, where they feel more resilient. And then to a place where they feel like all of that work was worth it because I can imagine a life I want to live. Even if that pain is still around, I imagine a life I want to live that feels meaningful to me.